Hello and a warm welcome to this EMIC Fireside Chat online. My name is Gregor Henderson. I'm a board member of the Mental Health International Collaborative, and it's my great pleasure to be your host for today's webinar. This is an extremely important and exciting topic. Education for well-being. Is investing in digital mental health literacy the key to reducing the burden on clinical services? Or if I put that another way, rather than the burden on clinical services, is it key to enhancing improved mental health care utilization through education and improving the population's literacy around mental health and mental illness? We've got a range of key discussion points, which you will have seen in the advertising for this evening's and this morning's, wherever you are, webinar. So I won't go through those in any detail. But let me just say that one of the experiences I had when I was Director of Mental Health at Public Health England is we had the desire to produce a national mental health literacy resource. That turned into a set of resources under the banner of Every Mind Matters. And we have done some evaluation of Every Mind Matters if you're interested. But we were very taken by Stan Kuchar, who's one of the speakers by video this evening. And we were very taken by his definition of mental health literacy. And we spent a lot of time working out how we could best do that. And it became a free-for-all digital resource to improve the population's mental health literacy. If you're interested in finding out any of the evaluation of that, then just Google Every Mind Matters evaluation, and you'll see work from UCL and King's College London that comes up. And if you just click through that, you'll get some of the feedback and some of the results from that evaluation. But it's an extremely important topic, and we have got some amazing panelists from both Canada and New Zealand who are all working hard to make a tangible impact on populations, on individuals, on those from priority communities. And you'll hear from each of them first soon. But first, let me just mention a few quick points. Please feel free to share your current location and areas of interest. To do so, you can click on the three dots next to your name tag, choose Edit, and add your country or area of interest. This allows you to connect with others who share similar interests. If you have any questions for the panelists during the webinar, please feel free to post them in the chat box. And during the Q&A, I'll do my best to include as many of them as possible in our discussions. Lastly, today's webinar is being recorded, and the EMIC team will soon share the recording in the Knowledge Bank. So thank you very much for joining us for this webinar. And now it gives me great pleasure to introduce our first speaker of the day. Our first speaker is Senator, the Honourable Dr. Stan Kuchar. Stan is an internationally renowned psychiatrist in adolescent mental health and is now a senator in the Canadian legislature. Stan is a leader in mental health research, education, advocacy, policy, and services. And he previously worked at the University of Toronto and Dalhousie, where he was the departmental head of psychiatry, associate dean of international health, and the Sun Life Financial Chair in adolescent mental health. I've known Stan for many years, and I have found his work to be supremely influential in work that I've been involved with my colleagues in England and right across the UK. So we're going to have a video presentation from Stan for the next 5-6 minutes. So Olivia, EMIC assistant, please let's play the video.
Hi there, I am Senator Stan Kuchar, and as you can see, it's Casual Senate Day today in Ottawa. Thank you so much for inviting me to give you some of my thoughts as you settle into deep deliberations and innovative ideas related to mental health literacy. Now, mental health literacy is an offshoot of health literacy, and the WHO position paper on this of 2013 still is a good foundational piece to begin with. Mental health literacy is the foundation for mental health promotion, prevention, understanding how to access care, when to access care, and is essential for improving mental health care outcomes. It has 4 components: knowing how to obtain and maintain good mental health, knowing about mental disorders and their treatments, decreasing stigma, and improving help-seeking efficacy. That's knowing when and where to get care and how to interact with the healthcare provider so that you will get the best care possible from that provider. The other thing is that increasingly we are becoming concerned that we have to help individuals better address, identify, and deal with mental health misinformation and mental health disinformation. So those are the components of mental health literacy. Mental health literacy must be based on best available evidence. So the interventions that are applied under the title of mental health literacy must have had extensive research, replication research, high quality research, showing significant, substantive, and sustained impact on a number of domains. Those are knowledge, attitudes, behaviors. And those behaviors can be initiation behaviors, consideration of behaviors such as help seeking, and increasingly we are concerned about outcomes. What is the outcomes of those behaviors? The delivery of mental health literacy must be developmentally appropriate. What is a good way to provide mental health literacy for 5-year-olds is not the same as we do for 25-year-olds and not the same as we do for 55-year-olds or 85-year-olds. So it must be created in a manner that is developmentally appropriate. It has to have attention paid to ethnocultural components and to language. Both of them are fundamentally important for understanding and delivering mental health literacy interventions. Mental health literacy can be delivered to an individual, either directly to the individual, such as online or electronic methods, or through a third party, such as a healthcare provider, an educator, or a human services worker. The individual delivery can be directly to the person and also indirectly to the person, as I have mentioned. However, mental health literacy should also be provided through recognized, persistent, and substantive social institutions. The first one is obviously the family. And here, mental health literacy interventions that are at the family level, which also can be delivered through, for example, primary care healthcare providers, should be part and parcel of every family's experience. Furthermore, we have institutions that help young people develop, particularly schools, primary, secondary, and post-secondary. And those schools must be able to deliver best available evidence-based mental health literacy interventions because they are set up to deliver literacy and they can do it developmentally appropriately. But the educators must be appropriately trained to do so. And then we have workplaces, which is the other large institutional component. And mental health literacy in the workplace is an area that really needs further study. Now, it is so important that mental health literacy interventions be best available evidence-based. As mental health literacy has become more on the public's radar, sadly, there are a lot of fly-by-night operations, some well-meaning, that have created products or services and put a stamp, this is mental health literacy. Unless an intervention addresses those 4 components that I mentioned at the beginning of this talk, plus the issue of disinformation, it can't be a mental health literacy intervention, and unless those interventions and products have demonstrated significant, substantive, and sustained positive impact on knowledge or attitudes or behaviors or outcomes or all of those components. They're not mental health literacy interventions. So part of what we have to do is to not only help people become mental health literate, but assist them in being able to choose what actually is mental health literacy. So as you continue your deliberations, I hope that this overview has been helpful to you, and I look forward to hearing about the outcomes of your work. Thank you very much. À bientôt.
Well, thank you, Stan. It was a great video. Really, really impactful hearing about the absolute crucial role of definitions, having the evidence and the impact, and making sure that all of those things are in place to have the right kind of system-wide impact. It's great hearing Stan again. Okay, let's go to our second speaker. It's my great pleasure to introduce Dr. Yifeng Wei. Yifeng is an expert in school-based mental health literacy and an assistant professor with the Department of Psychiatry in the University of Alberta. Yifeng is a consultant to an organization called Mental Health Literacy, and her research focuses on promoting mental health literacy in schools and the community to help children and youth gain better understandings about mental health and mental disorders, reduce stigma, attain and maintain good mental health, and enhance health-seeking behaviors. She has made a significant contribution to school and community mental health research, program development, and implementation across Canada and around the world. Yifeng, it's great to have you with us, and we look forward to your contribution to today's webinar.
Thank you, Gregor, for your nice introduction. Hello, everyone. It's a great pleasure and honor to present and share my experiences working with schools in Canada and internationally using the mental health literacy approach to address child and youth health. I'm going to do a very quick presentation to share my work in Canada and in other countries as well. Okay. So we have applied mental health literacy approaches to improve the mental health of diverse communities in different settings, especially in the school setting. The mental health literacy approach is built on the population health model, which is a three-dimensional model created in Canada, but has been translated and widely disseminated across the world. At the very front of the diagram, you will see a series of health determinants we will address using the population health model. In terms of mental health literacy approach, we are using this model to address the social and health determinants such as social support network, education, physical environments, personal health and practices and coping skills built in children and youth and related stakeholders, and healthy child development and health services. To achieve these goals and social determinants, we use a community-based strategies, which you will see on the side of the diagram, using a number of strategies and actions, policies to address child and youth mental health. For example, to strengthen community action, to build healthy public policy, which is what we're doing right now, and create supportive environments and develop personal skills. And we have engaged everybody, pretty much everybody in the community who are children and youth, and who are people who support children and youth. Basically, they're individuals, families, parents, community, and a healthcare system, educational system, and civic system, and the whole society together to address child and youth mental health. And mental health literacy is the foundation for everything we do. Without this solid foundation, every the other blocks at top will fall. So that's why we build these concepts of mental health literacy that integrate interrelated four components that Dr. Stan Kuchar just shared. And shared literacy is important. Shared literacy among children and youth and related stakeholders, in which you will see that we have listed a number of key stakeholders in the community to support China youth mental health. And actually, basically and literally, everybody should have shared mental health literacy so we can talk to each other with the similar language when we address China youth mental health. And based on the concept of mental health literacy, my team, working together with stakeholders and children and youth, we have created a series of evidence-based mental health literacy interventions and resources to be delivered in different school settings and community settings. At the very top of this slide, you will see the programs, interventions developed for developmentally appropriate resources developed for elementary grade 4 to 6 students. And you will see high school curriculum guide developed for students from grade 7 to 12 and to 11. And then you will see a specific intervention developed for grade 12 students, which is the last year of high school in Canada. And then also we have continuous programs, interventions built into the post-secondary settings all together to address China youth mental health. And around these key resources for children and youth, we build key stakeholder interventions for teachers, such as the go-to-educator training for any educators, children and youth naturally go to in the educational settings. And we also build training for teachers, classroom teachers, to teach all these resources and interventions embedded in the regular classroom. And we also build support mental health literacy interventions for parents and families, for sports organizations, for primary care providers, because here in Canada, the first healthcare provider children and youth would need when they address their health concerns are primary care providers. And also we have pre-service teacher training to train teachers to prepare them to get ready for their educational career. And through the implementation and development of these resources, and through the implementation and evaluation of these resources and interventions, we naturally build a pathway through care model, engaging everybody in the community between health and education system. And here I just want to highlight a few examples of evidence-based programs our team has achieved. For example, the go-to-educator training to train educators in the school setting to early identify students who may be at risk of mental health problems or mental disorders is highly effective in terms of early identification and referral of students at risk to get appropriate care. So this big study involving more than 500 schools in Canada, in Calgary region, here in Alberta province, demonstrated successful early identification of students to go to healthcare and receive appropriate care. And then what is more important at the end of this intervention, when students refer to the healthcare system, their health outcomes improve significantly at discharge. And then we also have primary care provider interventions that we just finished primary evaluation demonstrating very positive outcomes in terms of knowledge, stigma, and help seeking. And the high school curriculum guide is significantly important for our team because this is the first evidence-based intervention we created and tested with randomized control trial, which demonstrated significant improvement in knowledge and reduction of stigma. And this high school curriculum guide was adapted and widely applied in Wales, which demonstrates similar significant results among younger students aged between 13 to 15. So all these programs have demonstrated strong evidence of effectiveness, indicating this is a plausible way to be embedded in the classroom. And we have also identified some implementation barriers that we have to address when we're implementing these programs. And one of the solutions is to use digital platform or digital mental health literacy interventions so that we can reach out to more audiences and communities. And this is what we're doing right now in Canada in terms of elementary resource and Indigenous mental health literacy interventions. Thank you.
Great, Aoife, thank you very much. Sorry for having to come in. I'm just so keen to get everybody's views, but that was an amazing presentation. Thank you. And I really like the way that you are meeting Stan's requirement for evidence, impact, really good studies, and RCT in there as well. That's amazing. I also really like the emphasis on school, but the whole community of stakeholders and workforce that is working with the children and youth, and having them absolutely sharing the same language through the mental health literacy and education they receive. That was extremely powerful. Thank you. Okay, let's move on to our next speaker. It gives me great pleasure again to introduce Anna Dorsey. Is the founder and CEO of Headlight New Zealand, an experienced public health professional who since 2021 has been leading a unique mental health promotion project that is making mental health education accessible and engaging for diverse and hard-to-reach populations in New Zealand. She stepped away from her successful career leading national health campaigns in 2020 to actively support the mental health and well-being of the Queenstown community in the southern island of New Zealand following the devastating impact of COVID on its local tourism-reliant economy, residents and businesses. Her team's experience to date delivering mental health education on the ground in communities is informing a new model of digitally delivered, equity-led mental health education delivery that has significant potential to support widespread engagement by priority audiences in increasing their mental health knowledge and skills. Anna, we're so looking forward to hearing from you. Thank you.
Thank you, Gregor. It's a real honour to be here. Thank you so much for the opportunity to share our story. Right, I'll just go into my slides. So I'm going to talk today about our unique project. And the question we wanted to answer today is, how do you increase mental health literacy in diverse community settings? So I spent the last 3 years leading a unique project in Queenstown, New Zealand. Our small town is well known as a tourism destination and was heavily impacted by COVID. The closure of the borders put huge pressure on our local population, and our tourism-reliant economy experienced significant stress, and many, including our large migrant population, had barriers to accessing mental health support. This included our overloaded local health system, stigma and cultural barriers to reaching out for help, but also strong fears around the implications on their visa status and potential deportation if people reached out for help. So our team worked with the community to create a unique pilot project in response to a request for support to support mental health. And our goal was to bring mental health literacy training to priority populations and hard-to-reach communities, to help people support their own mental health through this time and to support those around them who are struggling. So I'm going to talk about the Gujong Community Pilot. Our pilot adapted an existing clinically developed mental health literacy program that was being delivered by peers within large workforces and workplaces. We took a local license for this program and recruited a lived experience local workforce from our priority communities. This included migrants, new parents, and small business owners. And these were groups really impacted by COVID. So our plan was that those individuals could connect with their people in their community and build trust and engagement so that people would come together in safe spaces to learn about mental health through experiencing a brief 3-hour workshop. We supported our diverse team to make the training accessible. It could be delivered in multiple languages, in different settings, and in ways that was led by the needs of the community. So from the kitchen table to rugby clubs and plunket rooms, it was about getting to where the community gathered. During the 14-month pilot, we had 267 workshop participants, and this was during a time when we had another lockdown and several waves of Omicron, putting a strong halt on many face-to-face community activities. We had really high attendance and engagement from ethnically diverse communities. 43% of people had English as a second language. And what's important to note is that these people gave up their weekends and evenings to come together to talk about mental health. We saw strong learning outcomes in terms of mental health literacy measures. And in addition, 97% of people strongly agreed that their training increased their knowledge of mental health and wellbeing. And our own survey data showed that 90% of people had applied the education within 3 months of doing the training to support their own mental health and or the mental health of someone around them. We knew that this training was bringing people new information that they weren't finding elsewhere. Our team worked with an external evaluator to publish a report on the impact of the pilot program during the first 14 months of its delivery. And you'll find this report on our website, headlight.org.nz. The evaluation found that the program increased mental wellbeing, particularly in hard to reach and ethnically diverse communities. And the peer-to-peer model was really key in overcoming stigma and discrimination, removing barriers and building trust and engagement in the community. And by educating those around people who are vulnerable, our pilot was creating a ripple effect to support the mental health and wellbeing of the wider community. We heard stories of how people were using the education to help others around them, both in person and even through Facebook, with people reaching out to each other, using the training to help them talk to those who were struggling and helping them navigate tough times. We realised that we were gradually growing our diverse team of health connectors in our community who stayed here after the training and were able to connect with and signpost people outside of the workshop, which is really key. This means we were building capacity and capability in our rural community, a place where it's expensive to move to, and we are continuously under-resourced in terms of clinical workforce. Overall, the program was found to have a potentially deep and long-term impact on the mental wellbeing of the community. So we have continued to deliver the program in the last 12 months and have had high engagement in ongoing. Over that time, we've learned that mental health literacy programs can be delivered to diverse priority communities. However, there are some key things we learned. One size does not fit all. Education needs to be equity-led so that it is accessible for those who most need it and removes barriers to engagement such as language, setting, and location, and cost. Workshops were free or subsidised to small businesses. By working with each priority community, we were able to learn about how they were structured and who the trusted doorways were. So once you identified those people, you were able to build engagement with hard-to-reach groups. Using a non-clinical, lived experience peer workforce was really powerful in its ability to build engagement and reduce stigma in communities. However, a peer workforce needs support and supervision to do this work. We paid our workforce, they weren't volunteers, and we supported them to do their jobs safely and effectively, and that was really important. So looking ahead, we believe that this program highlights the potential value of investing in community-based mental health literacy programs in terms of impacting mental well-being, but there isn't currently any funding mechanism in place to bring this to more communities. We believe that such programs need to be done in a way that is sustainable and scalable. And we think digital tech holds the key to achieving scale and engagement. People wanted to learn and meet in person. They wanted safe spaces. And tech can support us to share this education in a way that takes pressure off facilitators, but still supports safe conversations and delivery at scale. And we are taking the journey now into innovation and learning so that we can make mental health education more accessible. But this isn't something that one community should be doing on its own. It's something that our collective global community should be supporting investment and exploration in. And we believe this work is really important. And through collaboration, I think this is the key to success. So we invite others interested in this strategy to work collaboratively on this journey. Thank you.
Anna, thank you. That was absolutely great. I just love those lived experience examples. I think that's absolutely key. And the strong results you had again, Stan would be applauding from the sidelines on the research. 90% applied the knowledge following the educational training, around mental health literacy. That's really quite phenomenal. So congratulations to you. And I agree with you. The whole aspect of sustainability, investment, and collaboration is key to all that. Okay, that brings us to our fourth and final speaker before we get into panel discussion and then engagement with the audience. Our last speaker is Dr. Andy Greenshaw, who's the Professor of Psychiatry and Neuroscience and Scientific Director for the APEC Digital Hub for Mental Health. Andy is a Fellow of the Canadian College of Neuropsychopharmacology, I had to say that slowly, for which he served as President from 2002, and the Collegium Internationale Neuropsychopharmacologicum. Andy served as President of Alberta Associate Vice President and is a member of the Scientific Advisory Board of the CIHR Institute of Neuroscience, Mental Health and Addiction. Andy has broad research interests that range from neuroscience to policy in mental health, with particular interests in AI and machine learning applications and e-health. Andy, looking forward, as always, to hearing your contributions. Thank you.
Thank you very much, Gregor, for a real mouthful of an introduction. I appreciate that. It's a real pleasure to be here at an EMEC webinar again. I think EMEC is doing fantastically important work and is centrally positioned to host these discussions. Before I start, I want to acknowledge that I live on the traditional lands of Indigenous people, the Cree, the Blackfoot, the Nakota Sioux, the Anishinaabe, Saulteaux, home of the Dene, and the Métis Nation of Alberta in what is now Treaty 6, Treaty 7, and Treaty 8 territory. So this is a fantastically important area. I really enjoyed Stan's video where he captured all of the main elements, and then we went into Yifeng Wei's work with school and children and Anna Dorsey's work with an adult community. I think that conversations with Stan early on really showed me the value of mental health literacy as opposed to dealing with stigma. Many people still talk about stigma and how we need to identify stigma to combat the discrimination that happens. When we think about this and get into the details, we realize that prejudice and discrimination come from a lack of understanding. And simply understanding the label stigma and knowing that it's not appropriate for superficial reasons to think in any negative way about mental health and to be supportive is no substitute for knowing the details. So understanding the lived experience of people with mental health issues, understanding what caregivers deal with is critically important. And mental health literacy is the only pathway that I can see that will improve things. We know from an old study of the World Health Organization that mental health and addiction, labeled mental health particularly, is the biggest global health problem we face. And if we're going to combat the problems of mental health and addiction, we really have to engage the community, have advocacy, and break the system that we're in now in a positive, disruptive way by enabling greater capacity. It's not really bringing more professionals onto the scene. It's really educating the public, whether that's children in schools, their teachers, administrators, parents, and family. I really like the juxtaposition of Yifeng and Anna's work because here you have school mental health and adult communities coming together. This is different in different parts of the world. It has the same general thrust. We need evidence. We really will need digital engagement to reach the capacity and reach remote and rural populations and underserved populations. Internet is spreading. It's logical to try and have digital solutions. We, with Anil Thaplial, I was in Geneva just last week with the World Health Organization and the United Nations talking about mental health challenges for children and youth. And central to that conversation, everybody in the room agreed that mental health literacy was an absolute key. We really need to move forward on this with evidence and programs that work to inform people. In medicine generally, we have the principle that if you can intervene early, you have a much better outcome. So understanding mental health problems, the more people in different workplaces, kids as an example, spend 8 hours a day in school, more time than they do with their parents. People understanding mental health issues there is a huge step forward in terms of moving forward, identifying problems and providing support. Anna's work in a community that was wrought with difficulties by COVID is a perfect example of how that helps with the evidence she presented. In the Philippines, we're launching digital mental health, and Anil and I will be in the Philippines in November to look at some mental health programs. Part of that's mental health literacy. In poor and vulnerable populations in the Philippines, very difficult to get through to a whole bunch of people. So the idea is there's an existing project called Atapan where they recruited people of responsibility in communities to be the ambassadors to taking things forward. So you can imagine if you can get through to key people in communities and with trusted relationships, you can spread things out in terms of implementation of positive developments for mental health literacy. And there, digital doesn't necessarily mean online. We can build some of these digital packages that are being promoted by, developed by people like Yifeng and Anna that don't need active internet, where you can actually play and have an interactive experience with a digital module online. There are lots of things to talk about. I'm looking forward to the discussion. I'm going to end it there. Thank you.
Andy, that's great. Thank you very much. And I just think that whole notion now in terms of the call to educate the community and the public and ways in which we reach them through digital technologies is absolutely key. Okay, I'm going to invite all of our speakers to come in for a panel discussion. Audience members, thank you very much. Please stay with us, and can I remind you to post your questions into the chat. We've got some areas that we want to explore. So for the next 10 minutes, I would like to explore a little bit more detail some of the questions that we raised in the information we sent out around this webinar. So the first one really aimed at Yifeng and Andy. And I want to just ask, what are the examples globally where investing in mental health literacy is improving mental well-being indicators for priority communities? Yifeng, do you want to take that first, and then I'll come to you, Andy, for some brief responses?
Yeah, sure. This is a big question, Gregor, but a good question to ask. Yeah, internationally, mental health literacy interventions have been emerging as a major to play a major role in terms of addressing child and youth mental health. Take my team's programs, for example. We have created a series of interventions, as I shared with everybody, that have been extensively translated and implemented in different international settings. For example, the high school curriculum guide has been implemented and adapted and translated and widely disseminated in more than 20 countries right now and across continents, including Canada. Let's just give you an example: Canada, United States, Costa Rica, and Guatemala, and Wales, and Singapore, Japan, China. Right now has been doing big research studies, and UK is doing a nationwide study on the impact of the high school curriculum guide that bring some of the good examples. I would just take Wales as an example, has finished a large RCT randomized control trial on the impact of the high school curriculum guide among youth of 13 to 15 years of age in Welsh schools, and demonstrating substantial and significant improvement of knowledge, significant reduction in stigma, and significant healthy behaviors as a result of the intervention, and better coping skills based on the large RCT study just released last month. So
I mean, that's amazing. So, like 20 countries around the world. Is there a forum or a symposium or an event that you pull all these people together to every year or every 2 years? I mean, this sounds like a community that's got some momentum and learning to share. Is there any thought to that?
It would be wonderful if we can bring some key representatives in from different countries together to talk about their different experiences, how an evidence-based program can be adapted and especially culturally adapted and used internationally, either through like in-person implementation or online implementation. And I bet we will learn from each other quite a bit. For example, Germany just adapted the program and translated into German and did a study and a cohort study and published their results recently. So if you are able to sponsor us to come up with a symposium talking our experiences, I think people will be appreciated.
I think that's phenomenal. Andy, is there anything you want to add to that?
Yeah, I just want to extend it a bit. You know, there's a lot of discussion in developed countries about the importance of mental health literacy. Of course, we have to recognize that a lot of countries around the world, that some developed, some not very well developed. China's been advancing a lot in the last 10 years and has bold ambitions to really address mental health problems. But when you go to places like India or the Philippines, I'm part of the APEC Digital Hub, which is 21 countries around Pacific Rim. There are lots of places where mental health has not been a major priority. And the misunderstanding is that if you don't deal with mental health, you're going to have bigger health problems because mental health and physical health are together. One of the challenges I'll put out to poor Yifeng and Anna, it's an awful thing to dump on your shoulders, but it's a broad community here, is that we really need to talk about mental health literacy in the context of general health. You know, if you have a physical health problem, you're going to have a mental health problem. And if you have a mental health problem, highly likely there's going to be a physical health sequelae. And the gap between physical and mental health is really a very fertile place. Not many people are building there. And I think it's a huge opportunity right at the beginning to press the button on understanding that important globally and in an integrated way.
I think that's crucial. And Stan said at the beginning, mental health literacy is a subset of health literacy. And I look at some global health conferences. There's one on at the moment. And I think we sometimes need to be a little bit more bolder and getting into the general health landscape because they need us more than they actually realize. Anna, can I come to you and ask a question here, which is, what can we learn from communities with regards to how they want to actually engage with mental health education from your experience?
Thank you, Gregor. Yes, I think just to build on some of the comments in my presentation, we have learned a lot from our community. We really saw the effectiveness of taking a community development approach and thinking about removing barriers to access, and especially amongst our ethnically diverse communities. We were really, blown away by the engagement of our Filipino community initially. As soon as we empowered Filipino community members to deliver this education, we filled rooms, and it was so interesting from a public health approach to see, the significant engagement that we had from those communities who wanted a safe space to talk about this topic. And I think a big word I want to just highlight is trust. We trusted our lived experience peer workforce with this education, and that took a bit of a leap of faith, but the impact of that was so significant in terms of building connection, reducing stigma and discrimination within that community, and building engagement. And I think that is what the sector can learn from this program specifically, is that you can trust a peer workforce to be your arm for the delivery of this type of training.
Fantastic. Yifeng, can I come to you just for some quick responses to the question around what is the appropriate way to approach mental health literacy training for diverse, rural, and remote communities? Can you give me some of your wisdom around that?
Not necessarily wisdom, but some probably lessons learned and some experiences working with diverse groups of populations. As Stan indicated at the very beginning, mental health literacy interventions should be context-based and developmentally appropriate. We realized how different people, like different communities are, and different groups of people are in terms of addressing mental health and including child and youth mental health. And that's why our team, recognizing that need and the significant gap, we have started identifying the need and support need of diverse groups and translated the current general interventions into culturally, socially appropriate interventions for different diverse groups. For example, we are creating mental health literacy interventions for Indigenous youth across Canada, and realizing the significant differences from each Indigenous community. We are creating a general framework under which each community can use that content and adapt to their own individual context. So that is the way we address the significant need of diverse group. That's just in one example.
That's fantastic. That's fantastic. Andy, can I come to you? Because a lot of people will say, okay, this is good, you got great research, but what's the economic benefit for communities investing in mental health literacy?
Well, in communities that don't have a budget for mental health and don't have a mental health strategy, the impact is obvious. You're injecting something that is effective and scalable based on evidence, and do it the right way with digital, very scalable. The other thing is, early intervention is important. For developed nations, we'd all, in Europe and North America, particularly, probably Australia and New Zealand, there are aspects of the health system that are simply broken. They're not broken. People threw money at the problem and didn't solve it. We need more capacity. If people understand more, they can share more. They can be more aware. They can use health services more appropriately. We deal with this in a streaming data project where we're trying to inform people about their health. Back in the day when I was a child, my mom had a thermometer. No one talked about mental health, but your body temperature was the key to you go to the doctor or not. Having the tools to understand what's going on and how you can be supported is a way that communities can bring back support. One brief comment I'll make is it's critical for children and youth. There's a lot of discussion about the suicide problem, suicide rates. And I go back to the original Durkheim stuff about anomie and being disconnected from community. When people are aware of mental health issues, they're much more capable of coming together and supporting people in a natural way. That's something we got away from in our technocratic society, and it's something that can be reinstated through mental health literacy training globally for anybody. I really believe that that's key.
Yeah, Andy, that's really powerful. That's really powerful. Members of the audience, if you'd like to put anything in the chat, any thoughts, any comments, any questions, please do so. Anna, can I come back to you? Because Andy made a powerful soliloquy there around capacity, tools, but also the way in which we can use digital technologies. What role does digital technology have, from your experience, to play in the delivery of mental health literacy and education?
Thank you. From our journey, we see that digital technology has a role very much as an enabler and a supporter of building access and scale, but also tailorability. We're on a journey to see how digital technology can help us tailor training to support specific communities, such as people with English as a second language. You can think about how that could support the access to training in a community setting without having to train multiple facilitators in each community. But we don't see digital as in isolation. We see it working in tandem with physical delivery, supporting people on the ground, because we've learned through our experience that people want to people predominantly if they can. I think there is obviously a strong place for digital solutions within that, but I think we still saw that given the choice, people would rather wait to meet in person than actually access digital training, which was really interesting. That was our experience. But we know that might be different for different demographics. But we're really excited about the potential of digital to open up the landscape for us to work collaboratively, internationally, and share training and tools that can support communities around mental health.
I think that's amazing. I think it's a really, really important topic. And being on the board of EMIC, and I know Anil's in the audience, I just think this is something, and Andy, you're very close to EMIC, this is something we should really be pushing a lot more, and I know we will. So thank you for that. We've got a question coming in on the chat. I hope I pronounced your name correctly. Apologies if I don't. It's a question from Tumukai Morgan. How do you balance the need for effective health education with the variance in young people's capacity for critical thinking in health? Well-intentioned messaging is only as useful as the extent to which young people can genuinely grapple with the content. Yeah, who wants to take that?
I'll have a go.
Well, okay, Andy, you go first, and then Yifeng will come.
There's some general principles that are really important here. It's a great question. Adaptation, culturally appropriate, was discussed already. And culturally appropriate and adaptation include developmental stages. We're talking to people of different cultures, religions, belief systems, and different ages. A key to this, and then I'll pass it to Yifeng, is co-creation. We've learned in the digital environment that you co-create with a community. Otherwise, I've got a widget for you. Thanks, what is this? It doesn't work for me. In Geneva, we talked about what kids want. There's a wonderful program called Chow that's been going for 25 years and now is digital. They ask teenagers what they want and at the level they can understand. Yifeng, over to you.
Thank you, Andy. You just said what I wanted to say. This is a great question. How do we engage participants, especially children and youth, to engage them into such a very sensitive but important topic in their lifetime? And as Andy indicated, we always use a participatory approach to co-create the materials instead of prescribing materials for the audience. I don't think prescriptions would work in this approach. So that's why when we created content, we have youth advisory group always taking the lead in terms of what content we should take and how do we deliver the content. And take just for transitions program, for example, for post-secondary students, we interviewed and surveyed over 1,000 youth before we created content in terms of how they would like mental health messages can be conveyed effectively and efficiently to them, and using what methodologies to convey all those information to them. So based on the feedback interview outcomes, we co-created the interventions. And then we also use DAVFA study approach to get content expert opinions and youth expert opinions and parents and families' opinions into this creation process. Otherwise, I don't think children and youth will take anything you prescribe to them. So here's breakfast. You have to eat it. Yeah.
Yeah. I wonder if they had that experience with the Philippines group, whether they started creating things in their own cultural niche. I mean, it sounds like you've had different groups convening, Anna.
Yeah. Do you want me to talk a little bit more about this? We found how different the different groups are in terms of different countries. For example, when Dr. Stan Kuchar first took the high school curriculum guide to Tanzania and Malawi in Africa, we didn't realize in their local language there isn't such a word to express the mental illness of depression and anxiety. There's no such local language describe disease. So and then we realized embedding the curriculum guide in the classroom is not the best way to teach about mental health. Instead, radio broadcasting is the best way, and drumming, and using drumming and different ways of delivering the message is completely unique in some African countries, and which turned out to be a great success because we engaged youth and local people into co-creation the material, which was originally quite westernized, but completely converted into a African, Malawi, and Tanzania context-based program eventually.
Okay, we've got another question coming in the chat, and Tumukai, it's from you again. Yeah, glad I got the pronunciation right. So alcohol and other drug topics are often approached differently within an educational context, particularly around pastoral or disciplinary responses, punished for one, supported with another. Given the overlap between mental health and alcohol drug challenges and mental health, what are your thoughts around enhancing synergy between the two in relation to mental health literacy and education? Anybody want to take that? And I've got one last question I'd like to ask everyone. Who'd like to come in on the mental health and alcohol?
I can comment briefly, Gregor. I think in the modern world, we're starting to understand that mental health or addiction are in the same tent. There used to be a time when a psychiatrist would not see somebody if they were not clean. That's not the case anymore. And a lot of people with addiction problems would never go to regular medical treatment because of stigma. So mental health literacy there is really important. And with young users, the whole literacy thing, opening things up and looking at reasons and causes. People don't become addicts because they want to. The idea that this is a disease. So it fits perfectly well. And I think we're moving in that direction.
Perfect. My last question is, and I know this is difficult given different contexts, cultural contexts, etc., but what does good mental health literacy look like? How would we recognize that a person has a good level of mental health literacy? Anna, can I come to you first, then Yifeng, and then Andy if you finish?
I think it really echoes Stan Kuchar's earlier video about the sort of pillars of mental health literacy, and they're quite universal and simplified, but they really create a really good foundation in an individual to think about their own mental health, but also the well-being of those around them. And that's really important for us on our journey, realizing that we're not just talking about you as an individual, but we're talking about you as part of your community, your family, your neighborhood. So I think mental health literacy is about a perspective which is internal, but also external. Yeah.
Perfect. Lovely. Yifeng, any thoughts briefly?
Yeah, just very quickly, I think there is a CAP model. We always utilize knowledge, attitudes, and help seeking as a core evaluation of mental health literacy interventions. And around this core CAP model, we build other additional very important outcomes such as stress, well-being, and quality of referral. And also other outcomes that each individual community is interested that will fit into the content of mental health literacy. I think that's very important for us to understand.
Perfect. Andy, anything else to add?
Yeah, very briefly, COVID pushed us over the digital divide. A lot of people were unwilling. They had to do it. We're there. Coming over the digital divide, many of us have realized the questions that digital has led us to ask the questions we should have been asking about the health system anyway. Mental health literacy has come up front and center as core because communications about things and understanding are really important. The one AI plug I'll put in here is large language models have now arrived. And in the technology for mental health literacy, they will play an increasing role. People are risk averse, but they offer a fantastic avenue for developing this in a way that's very accessible to everybody. It's already happening. Really great topic. Fantastic. Thanks.
Fantastic topic. Can I just say we're running out of time, or we've run out of time? I'd like to thank everybody for joining us, and a huge thank you to every single one of our panelists, all three of you. What a fantastic, great discussion today. That's it for today. It's been such a pleasure having you all with us.